we're going to learn about some conditions that in which the blood clotting is impaired. And mostly we are going to be talking about bleeding disorders. Then we're going to cover these conditions. We're going to be talking about the most common disorders that you're going to see in the clinical practice, and some others that are not so common, that probably you are never going to see, but they appear commonly in the boards. Okay, so they are going to be present surely in the files. Another test. Okay, so we are going to be talking about hemostasis mainly and disorders of the hemostasis. And it's important to know that, as in any hemostatic process, there has to be a balance, okay, for the body to work perfectly. So hemostasis, which is simply stop bleeding or the arrest of bleeding, depends on several factors in the body. One of them is the number and the quality of the platelets. Sometimes they are low in number, but sometimes they are normal in number, but they don't work properly because they are lacking certain structures. We also need some coagulation factors, many proteins that we have in the blood that are made mainly by the liver. And also we need perfect blood vessels. Okay, if the blood vessels are not okay, if they have any rupture, if they have any leakage, if they have any problem, also we are likely to have bleeding. Okay, so hemostasis depends on a balance between formation of the blood clot, for which we need a protein that is called thrombin that will form another that is called fibrin. Remember, for this blood clot we need many platelets together that are bound by proteins or by a network of fibrin proteins. And also there has to be a balance because we don't want all of our blood to clot when this process initiates. Okay, so there has to be a balance between formation of the clot and lysis of the blood by a protein that is called plasmin. Okay, so plasmin is antithrombotic and fibrin is prothrombotic. So there has to be a balance between them. Any problem with hemostasis will lead to hemorrhage. Okay, if we have any problem that increases bleeding, we can have external or internal hemorrhage. This will occur if we have low platelets or defective platelets. Will occur if we have missing blood clotting factors or something that inhibits the clotting factors. Okay, you're going to study several medications that inhibit coagulation. Heparin, warfarin, they act using different mechanisms. Also, we can bleed if we have any local or systemic disorder. A local disorder can be a traumatism, a cut that breaks the blood vessels. A systemic disorder can be, for example, diseases that produce vasculitis, inflammation of the blood vessels with rupture of the endothelial cells, and bleeding as a result. Also, if we have an increase in the clotting formation, we are going to have other types of problems, that is thrombosis formation. You have already studied, that leads to many different things like deep venous thrombosis, or pulmonary embolism, or thrombosis in different blood vessels. Hemostasis has different phases. Okay? The first thing that happens when there is a rupture in the blood vessel is vasoconstriction. Okay? Depending on the diameter of the blood vessel, this will be more effective or not. If we have a rupture in the little arteriole in the finger, it's very likely to control the bleeding, but if there is a rupture in the pulmonary artery or in the aorta, it's very difficult that it constricts and stops the bleeding. So we have to intervene. The second phase is formation of the plug, the platelet plug, that has several phases that we are going to see later. First, the platelets have to adhere to the endothelial cells that have the damage. Then they are going to secrete certain products that they have inside, some granules that they produce, ADP, serotonin, etc. And then they are going to aggregate. Okay, they first attach to the endothelium, and then they attract more platelets, and these platelets bind one to another, forming a plug. That is the first stage of the formation of the plug. Then there has to be a propagation of the plug. This is the third stage. This works in a positive feedback fashion. Okay, this is going to be produced by the coagulation cascade. We are going to see later, something that is can be really complicated when you try to study, but there are several mnemonics that you can use to facilitate the learning of this. Then we have to stop this. Okay? We don't want this thrombus to expand beyond where it's necessary. So there has to be a process that terminates by using anti-thrombotic mechanisms. Remember, plasmin is gonna act in order to stop the bleeding. Certain products that are produced by the endothelial cells are gonna stop this formation of the thrombus. And then we need the fibrinolysis, or the breakdown, once the body is okay again, that there is no more danger of bleeding. We have to remove the thrombus and leave everything as it was before the injury. So these are the steps, and what I want you to have clear is that hemostasis can be divided into primary or secondary hemostasis. Okay, primary hemostasis has more to do with the platelet formation, the plug formation. Okay, so we are going to have some disorders of the primary hemostasis that you have to differentiate from disorders of the secondary hemostasis that has more to do with the clotting factors. There are different types of bleeding. Bleeding due to defects in the primary hemostasis, or platelet type bleeding, and disorders due to failure of the secondary hemostasis. That is when the coagulation factors are missing or are inhibited. Okay, we are going to study some conditions in which this can happen. So let's try to understand this coagulation cascade. Okay, there is an explanation here with certain things in red, bold letters, so you understand what are the most important things. Okay, there are two pathways for the blood clotting formation. These two pathways occur because of studies that we do in vitro. Okay, you can take blood and you can add silica, which is a negatively charged particle. This activates the factor 12 of the coagulation. Or you can add something that is called tissue factor. Okay, that will activate other coagulation factor, is the factor 7. Okay, how this translates inside the body. Okay, here I have represented the endothelial cells. Okay, normally all of the things that are needed for the coagulation are here. Okay, but they never get in contact with the stimulators, which are the tissue factor that we have beyond the endothelial cells, or the collagen fibers that are under the endothelial cells. Okay, if these coagulation factors and platelets and all of these proteins get in contact with the tissue factor or the collagen, they are going to get activated. Okay, so if for any reason there is any rupture, imagine there is an injury here and we lose these endothelial cells. Now, the tissue factor, which is a molecule that is in the connective tissue under the endothelial cells, and the collagen fibers will get in contact with factor 7 and factor 12. Tissue factor is a receptor for factor 7. If they bind one to another, this factor 7 gets activated, and it starts activating other proteins in a cascade fashion. Collagen will activate the factor 12. This in turn will activate the factor 11, this will activate the factor 9, and this will activate the factor 10. And notice that the factor 10 here appears at the center of the coagulation cascade. This will activate other factors that will end up with the activation of fibrinogen, which is the factor 1. Notice that fibrin is the factor 1 activated, and the coagulation takes place. Fibrin fibers will bind all of the platelets together, forming the thrombus. Okay? We call this branch here the extrinsic pathway, and we call this branch here the intrinsic pathway. Okay? The extrinsic pathway can be measured doing a test that is called PT, and is inhibited by the action of warfarin, this prothrombin time, and the intrinsic pathway is measured by a test that is called partial thromboplastin time, or PTT, and this one is inhibited by the action of heparin. These are the anticoagulants that we are going to use when we want to inhibit one of these pathways and prevent blood clotting. Okay? Something important that you need to know about these factors. There is a mnemonic here that is it's the one that I used when I was studying medicine. I don't know if you have one that is better. 1972 is a year that I can't remember easily for some reasons. Okay? I transform the 1 in a 10, and 9, 7, 2, and these are the factors that are vitamin K dependent. Okay? So, if someone doesn't have enough vitamin K in the body, these factors are not gonna work. Okay? And there is a medication that is called warfarin that inhibits the action of vitamin K. That is for you to understand why we use warfarin and what warfarin will do in the body. Will inhibit the actions of an enzyme that allows the use of vitamin K by these clotting factors, the 10, okay, 7, the 9, the 10, the 9, the 7, and the 2. Now I want you to see this video, okay? It's a very good mnemonic that is going to help you. I uploaded this to Blackboard so you can watch it as many times as you want. Pay attention because it's very good, very easy to understand.
Guys, my mnemonic for the coagulation cascade. This is brought to you by Dirty USMLE. The coagulation cascade is extremely high yield for step 1. You have to have the actual cascade itself memorized, but you also have to be able to take that a step further and apply that to drugs, to clotting, to bleeding, etc. So today we're going to go through all of that, and by the end of this video, you'll be masters. This is a great mnemonic. So here's what we're going to do. We're going to get started with a common math problem. So the first number we're going to write down is 2, because we know that in the coagulation cascade, there are 2 major pathways. So because there are 2 major pathways, we start with the number 2. And then we write down the number 5, because we are trying to form clots, and clots has 5 letters. So far, there are 2 major pathways in the coagulation cascade, so we write down the number 2. Above that, we're going to multiply that 2 by 5, because we are trying to form clots, and there are 5 letters in the word clots. Now, 2 times 5 equals 10, that's just math. So the common math problem is 2 pathways times 5 clots equals 10, and that's just a math problem. So this is where we are so far. We've gone in order, writing our numbers up. Okay? This is the common math problem. Now we're going to look at those 2 pathways. We know that the coagulation cascade has 2 major pathways. The one on the left is going to be the orange pathway, and the one on the right is going to be the blue pathway. So here's what we're going to do. First, we're going to write down some letters. We're going to count down starting at 12. So we go 12, 11, 10, 9, 8. So all I did was count down from 12. 12, 11, 10, 9, 8. However, the number 10 was already used because, see, in the common math problem, we said that 2 pathways times 5 letters in the word clots equals 10. So because we already used the number 10, counting down from 12, we have to cross out the number 10. This is very simple. All we did was count down from 12, going down to 8, and we crossed out the number 10 because it was already used. Now, what number is left over if we were to continue counting down from 8? Well, 7. The only thing is that we've already reached our arrow, so we have to throw the 7 on the other side, on the blue pathway. So 7. So all I've done so far, I'm just going to review it really quickly so you have this in your head, is there were 2 major pathways, so we wrote down the number 2. We multiplied that by 5 because we're trying to form clots, and there are 5 letters in the word clots, and that equals 10. Then, in the orange pathway, we started counting down from 12 down to 8, where the arrow ended, but we already used 10, so we had to cross out the number 10. So 10 is not a part of that countdown. The next number left over was 7. But there wasn't any room left on the orange pathway side because we had already reached the tip of the orange arrow. So then I put the number 7 on the right side, on the blue pathway. Now, these are our 2 pathways. On the left we have the intrinsic pathway, and on the right we have the extrinsic pathway. The way that you can remember this is based on how many numbers are in each pathway, and that will help you remember the relevant clinical details. So, the intrinsic pathway has more numbers inside of it. Intrinsic, more numbers inside of it. The extrinsic pathway has less extra numbers. Less extra numbers. So we're going to write that in. Now, more numbers inside of it versus less extra numbers will help us remember a few clinical details. First is that when you're testing each of these coagulation pathways, you have to know which test, the PTT or the PT, applies to each pathway. Well, the one with more numbers inside of it is intrinsic, and more is in PTT, whereas less would be PT because there's less numbers in PT, but more letters in PTT. So more in PTT, less in PT. So that makes sense why PTT tests the pathway with more numbers, because PTT has more letters. PT is in the pathway with less extra numbers, because in PT there are less letters, and in the extrinsic pathway there are less numbers. So this just goes hand in hand. Heparin will affect the intrinsic pathway, and warfarin will affect the extrinsic pathway. There's really no good way to remember this. You kind of just have to memorize it.
Wait.
But once you've memorized the mechanism of
The way I use is I take this 11 and make it an H. 11 heparin.
heparin and warfarin, this becomes very easy. So I would refer you to pharmacology for that. And then the last bit of clinical information, which is actually very high yield, is you have to know that the intrinsic pathway has a longer time to form a clot. Or in other words, it's a slower pathway. Whereas the extrinsic pathway is a faster time to form a clot. It's shorter of a pathway. So that makes sense as well, because the pathway with more numbers inside of it, which is intrinsic, is going to take longer because there are more clotting factors that have to be generated. Whereas in the pathway with less clotting factors, the extrinsic pathway, less extra numbers, it's going to be a faster pathway, or you'll form a clot faster because there are less clotting factors to go through. Now the last detail that I want to point out is that our common math problem represents the final common pathway. So if you were to disrupt factor 10, factor 5, or factor 2, both the intrinsic and extrinsic pathways would be affected, because both of these pathways come down and lead to the final common pathway. So while in this mnemonic my arrows are actually going up, how it works is that if you're doing the intrinsic pathway, 12 is generated, then 11, then 9, then 8, and then 10, 5, and 2. And whereas in the extrinsic pathway, 7 is generated, and then 10, 5, and 2 is generated. So we're actually moving downward in reality. So what you need to remember is that if you're presented with a question on your USMLE or your COMLEX that says that someone has a factor 10 deficiency or a factor 5 deficiency, well, that's going to affect both the intrinsic and extrinsic pathway, because this is the final common pathway. And you can remember that in the context of the mnemonic, in that it was the common math problem. So once again, I'm just going to summarize everything from top to bottom really quickly, just so you have this down.
Okay, just what he doesn't mention there is that the common pathway is tested by the TT or thrombin time. Okay, so you can use the PT for the extrinsic, the PTT for the intrinsic pathway, and the TT thrombin time for the common pathway. That measures actually both pathways. So there you have the explanation. Intrinsic pathway is initiated by exposure to any negative surface. Collagen is a protein that is negatively charged. So exposure to collagen will activate this intrinsic pathway. The extrinsic one is activated by tissue factor and is tested, as it says, by the PT. Both converge using or activating the factor 10, which is the central factor. It makes like an X, so you can remember that because it's like a cross, okay? So it's in the center of these two coagulations. And all of these will lead to the activation of thrombin that will convert fibrinogen, which is the factor 1, into factor 1 activated, that is fibrin, okay? Fibrin will form or join all of these platelets together. This can be tested by using the TT. This is a diagram that is really complicated, but more or less when you watch this video, when you see these mnemonics, you are going to be able to understand better this thing. Here you also have what inhibits the coagulation. For example, here we have protein S, protein C, thrombomodulin. All of these inhibit different portions of these coagulation cascade. We have antithrombin that inhibits other clotting factors, and we have tissue factor pathway inhibitor that is something that inhibits the activation of the extrinsic pathway. Okay, all of these in red are factors that inhibit coagulation. This is for pharmacology. This is not for pathophysiology. I just put it there for you to have clear what medications we use, where they act. Okay, there we have, remember, warfarin. That is an inhibitor of the vitamin K, so will affect the vitamin K dependent clotting factors. So you have warfarin here, inhibiting 2, 10, 9, and 7. Okay, we have the 10A inhibitors. We have heparin, that is anti-3. Okay, we have the 2A inhibitors. We have different medications, but that is for pharmacology. That is for to help you for pharmacology. We are not going to be asking anything about medications in pathophysiology, because you will have enough of that for pharmacology. Okay, tissue factor plasminogen pathway inhibitor, as it's represented in the diagram, inhibits the complex between factor 7 and the tissue factor, which is factor 3. Antithrombin 3, which is the most important in this limitation of the clot formation, is considered a scavenger that inhibits both the extrinsic and intrinsic pathways. It inactivates the 2, the 7, the 9, the 10, and the 11. Protein C is a protein that needs the presence of protein S to work, inhibits factors 5 and 8. And then we have the process of clot lysis, in which we have TPA, tissue plasminogen activator, that induces the formation of plasmin. Remember, plasmin is a fibrinolytic or proteolytic enzyme that will break down fibrin. When this is happening, all of these fibrin, or the products of the degradation of fibrin, is going to go to the circulation, and we can use or detect these fibrin degradation products to determine if the patient is having any disorder, like DVT, like pulmonary embolism, or any process that includes formation and breakdown of blood clots. We call these products D-dimer, and this is the test that we are going to do to diagnose certain conditions in our patients. So remember, we are going to have two types of bleeding, basically. One that depends on platelets or platelets defects, that is the platelet type bleeding. And we are going to have one that is due to coagulation or blood clotting disorders. Okay, that will be our approach to the patient. What is the type of bleeding that the patient has? Normally, platelet disorders will have a bleeding that occurs immediately after injury. Injury can be apparent or not. Sometimes they don't recognize where the injury occurred, and this will affect the skin and the mucous membranes. People are going to have petechiae, bruising, nosebleeds, increased bleeding with the menstruations, menorrhagia, okay? Bleeding from mucous membranes and skin, superficial bleeding. The coagulation, the blood clotting related bleeding will be delayed in onset. It doesn't occur immediately after the injury, okay? And will produce ecchymosis or hemarthrosis, which is bleeding inside the joints, or hematomas, okay, because of congenital or drug-induced absence or problems with the coagulation factor. Sometimes we are, for example, playing sports, and we fall. Oh, I injured my knee, but it's okay, it's okay. It hurts a little bit, but it's okay. Maybe the next day, the knee is swollen because there is a hemarthrosis inside the knee. It's a more delayed problem, doesn't occur immediately. Remember, when there is an injury in a blood vessel, there will be vasoconstriction. The platelets will go there to stop the bleeding. That's why we don't see anything immediately. But then we need the fibrin to hold all of those platelets there. If the coagulation cascade is not working, all of those platelets are going to be removed, and is when the bleeding starts. That's why this process can be more delayed. Well, we are going to study some disorders of the platelets. It's important to remember certain numbers, okay? We call thrombocytopenia when someone has a count of platelets that is below 150,000 of platelets per microliter of blood. If someone has 130,000, this person officially, technically has a thrombocytopenia, but we maybe don't give too much importance to that. Okay, we are going to follow up the patient. We are going to be careful what is going on with this patient. We have to be careful with what we call pseudothrombocytopenia that can occur because of problems with the technique of drawing the blood, of the techniques in the lab. If for some reason the blood starts clotting, we're going to have less platelets to count, and we can have a fake or pseudo thrombocytopenia, so maybe we have to repeat the test. We don't consider thrombocytopenia significant until it reaches 100,000. That's when the problems can start happening. That's when we start worrying about the patient. Because if the platelet count reaches 50,000 is when people start having risk of having hemorrhage with a minor trauma. This is the type of patient that we have to tell, be careful when you go to the shower, be careful when you walk, always use something to help you, remove the rugs, remove all of the obstacles at home, because you have to be extremely careful. Now, sometimes the platelets can be as low as 10 to 15,000, and in this case, there will be spontaneous bleeding that occurs without any trauma. They are very quiet, they are still, and they can have bleeding from the nose, from the gums, from any place. Gastrointestinal bleeding, from the bladder, from any place in the body where there is a mucous membrane or skin. And some people can have a severe spontaneous bleeding, of course, if the platelets are extremely low, okay, below 10,000. That can be fatal, because there is no way the body can stop this bleeding. This thrombocytopenia can be caused by aplastic anemia, as you studied before, leukemia, something that produces a failure in the stem cells. Sometimes these platelets can be sequestered, stopped, and trapped in the spleen. Okay, people with lymphomas, leukemias, massive infection, any condition that enlarges the spleen, produces hypersplenism, chronic inflammation, or sometimes because of increased destruction. Increased destruction occurs in certain autoimmune conditions, okay, or consumption of the platelets. If someone has a disseminated coagulation of the blood, disseminated intravascular coagulation, the platelets are going to be consumed by these clots forming everywhere, and there are no platelets available for blood clotting. Okay, you're going to see that DIC, disseminated intravascular coagulation, is a disease that is characterized by clot formation everywhere, okay, but massive bleeding. Even though they are clotting all of the blood, they have extensive bleeding because there are no platelets available for the coagulation of the blood. So these problems with the platelets rarely are congenital. It can be, there are some congenital syndromes that are very rare that can produce thrombocytopenia, or sometimes can be acquired, in most cases, and can be primary or secondary. Remember, we call primary or essential to something that we don't know the cause. Okay, you have a thrombocytopenia, but I don't find anything that explains this. There is a cause, of course, but I don't see the cause. Okay, so this is idiopathic, this is primary, this is essential. Secondary to viral infections, for example, Epstein-Barr virus, rubella, cytomegalovirus, HIV, some drugs like thiazides, estrogens, quinine, chemotherapy. I put in bold letters ethanol. Alcoholism will lead to thrombocytopenia. Some people don't recognize, and this may be part of these idiopathic problems. You're going to learn in Patho 2 that there are some tests that you can do to determine if someone is drinking a lot of alcohol or not without telling the patient. Some nutritional deficiencies, remember B12 and folic acid are necessary for the production of blood cells, not only red blood cells, all of the cells in the bone marrow. Chronic renal failure, okay, bone marrow hypoplasia due to aplastic anemia, radiation therapy, infiltration of the marrow because of a leukemia, because of any cancer that infiltrates the marrow. But the most common forms are those that appear because of increased consumption of the platelets. Very common condition, or not very common, but very commonly seen in the clinical practice, heparin-induced thrombocytopenia. Patients that are having certain type of heparin that develop a thrombocytopenia. ITP, which is called idiopathic, was called idiopathic thrombocytopenia purpura in the past. Now it's called immune thrombocytopenic purpura because we didn't know the cause before, but now we know that it's an autoimmune condition. Notice that all of these idiopathic conditions, one day we know the name, the cause. TTP, or thrombotic thrombocytopenia purpura, and DIC, disseminated intravascular coagulation. These are the ones that appear more commonly in the clinical practice and in the boards. But you have to know that all of the other causes also can produce thrombocytopenia because we have to make a good differential diagnosis with our patients. So let's take a look at heparin-induced thrombocytopenia, or HIT. You're going to see this acronym in many books, HIT, or heparin-induced thrombocytopenia. This is the most common cause of drug-induced thrombocytopenia. Please read carefully when you are studying, because this is not the most common cause of thrombocytopenia. This is the most common cause of drug-induced thrombocytopenia. Okay? This occurs in 4% of the patients that are treated with on-fraction heparin, but only in 0.1% of the patients that use low molecular weight heparin. Okay, so it's going to be found commonly in those that use on-fraction heparin, but not very frequently with low molecular weight heparin. So you understand why we use one or the other. Now, what happens when we treat a patient with heparin? Okay, sometimes heparin will bind to proteins in the platelets, okay, and will produce a severe immune-mediated adverse drug reaction, okay, caused by IgG antibodies, okay, that are called anti-heparin platelet factor IV, that lead to platelet activation. That means heparin binds to a receptor in the platelets, that is platelet factor IV, and this complex is recognized by the immune system as something very dangerous, and we form these IgG autoantibodies that target these platelets. So platelets that are covered by antibodies are going to be removed from the circulation by macrophages in the spleen. So the platelet count will start dropping normally between 5 to 10 days after the administration of heparin, leading to an average platelet count of 60,000. So remember, if this is above 50,000, maybe it's not going to produce too much bleeding, because when the platelets go below 50,000, this is when we start seeing the bleeding problems. It doesn't produce bleeding, but it can lead to life and limb-threatening venous or arterial thromboembolism. That is the real problem with heparin-induced thrombocytopenia. They don't bleed too frequently, but they can have thrombosis in the legs, in the arms, in the brain, in the heart, veins, or arteries. That is the real problem with HIT. So the hallmark of the condition is thrombocytopenia, but the manifestations are not bleeding. Remember, bleeding is uncommon. Okay, the risk is thrombosis in different arteries or veins. Think in the patient that had a surgery, received heparin for the surgery, is discharged, and when he's at home, 5 to 10 days after the surgery, at home, starts developing thromboembolic events. This is the type of patient that appears in vignettes. Okay? There will be a decrease in 50% in the platelet count in more than 95% of the individuals. So if someone has a normal platelet count of 150, it's going to go down to 75,000 platelets. 95% of the patients that develop this condition, remember, decrease in 50% of the platelet count. 30% of those that have this condition are at risk for different thrombosis in veins or arteries. Okay, all of this process produces or increases the prothrombotic state. What will they have? Deep venous thrombosis and pulmonary embolism more frequently. What can they have also? Arterial thrombosis, limb ischemia in the legs, in the arms, or cerebrovascular accidents, myocardial infarctions. Other arteries that can be affected, any artery that you want to imagine, renal, mesenteric, or upper limb arteries. This occurs less commonly. So here the real problem is venous or arterial thrombosis This is an example of a venous limb gangrene of someone with HIT. I put this link here. This is not to be using Patho, but you need maybe this for your future. This is a calculator. You have a patient that has a platelet fall of more than 50%. You have a patient that has a clear onset between the days 5 or 10 after the treatment. We started treatment with the heparin, and we have thrombosis in this patient, and there are no other apparent causes for thrombocytopenia. This patient has a score of 8 points and has a high probability of HIT of more than 64%. This is a calculator that you can use in your clinical practice, or you can use to study, okay, in order to know how we make the diagnosis of these conditions. Okay, there is the link that you can use and play with it, taking things, putting things, and moving, so you see how the score moves up and down, and how the percentage of the likelihood of having an HIT increases or decreases depending on how many things are positive or negative in these patients. Well, this is for you to read. These are different drugs that are associated with thrombocytopenia. Okay, you have in bold the ones that are more commonly associated with thrombocytopenia. Remember, we have to rule out what medication are you taking to see if the thrombocytopenia is due to this problem with the drugs. Once you remove the drug, this should improve. Okay, we're not going to use this for your test, so you don't need to memorize these at all. By the way, I added a document in the drive, okay, that is very interesting for pharmacology. Has many clues that you can get from the names of the generic drugs to see what type of drug is and what is the mechanism of action. Okay, generic names of the drugs, you are going to see the suffix, the prefix of the drug, different things that you find in the names to see if this is an antibody, if this is a tumor drug, if this is a cardiovascular drug, what is the type of drug.
Where did you put that?
In the drive, in the first part of the drive, I think, right? Do you see it? No. Well, later we can take a look. Well, immune thrombocytopenic purpura, ITP, formerly known as idiopathic thrombocytopenic purpura. We still call it ITP because there is no change in the first letter. Okay, notice the incidence, up to 20 per 100,000 people in the general population. Okay, increases with age. And there is a higher incidence in females less than 60 years of age. There can be an acute disease or a chronic condition. Acute ITP. Acute ITP appears more commonly in children, and is a self-limited condition that lasts, in most cases, from 1 to 2 months. That is the typical presentation, okay? And there is a complete remission. It's a self-limited disease. Some children can have this condition up to 6 months, and some of them, 7 to 28%, may progress to a chronic ITP. But in most cases, remember, typically stops at 2 months without any complication. The type of patient is a child after an upper respiratory tract infection. They get viral infection, can be a cold, can be any kind of rhinitis or the flu, etc. Or sometimes because of exposure to drugs or because of lupus. This, of course, will be more causing people with these autoimmune conditions. After this upper respiratory tract infection, they tend to form complexes between antigens and antibodies. They have these complexes circulating. Okay, these complexes will bind to receptors on the platelets, leading to their destruction. Remember, something in our body that is coated by antibodies is treated as a foreign thing. Okay, antibodies tag cells for destruction. Once these platelets pass through the spleen, they are taken up by the macrophages and destroyed. So they are going to have thrombocytopenia because of increased destruction. Once the infection is gone. Once the medication is removed, this should go back to normal. Just a small percentage will go into a chronic ITP. Nowadays, we know many things about, because we are talking about viral infections, but now we are recognizing that some bacteria, like H. pylori, can be implicated in some autoimmune disorders. Remember, we talked about this in pernicious anemia. This is also true for immune thrombocytopenic purpura. So we have to look for H. pylori as possible cause of ITP. The chronic ITP is a similar mechanism. The problem is that it lasts longer. Okay, it's not self-limited, goes beyond 1 or 2 or 3 years. Okay, it's also caused by auto-antibody-mediated destruction of the platelets. This is more common in adults, okay, most frequently in women between 20 and 40 years of age. Of course, can be found in any person. Remember, some children go or progress into a chronic condition. This is not self-limited, but goes or gets progressively worse. Sometimes we know what is the cause, sometimes we don't know anything about exposures, so we call this primary. Primary or secondary chronic ITP. And here we have exactly the same mechanism. IgG antibodies target the platelets, okay, other receptors of the platelets. In the case of acute was the FC receptor. Now we have other type of receptors, 2B3A, 2B9. I'm going to talk a little bit about these receptors later. Okay, when they bind, remember, they are going to be removed by the macrophages in the spleen. Other cells of the immune system, like the T cells and B cells, also participate in this process. And what happens when we have this autoimmune process in the body? Not only the circulating platelets are going to be affected, also these antibodies are going to enter into the marrow and will suppress the development of the megakaryocytes. So the bone marrow is unable to make more platelets. And this is what explains why this is chronic. In the case of the acute, we destroy bacteria, we destroy platelets, but the bone marrow or the megakaryocytes are not affected. So once the infection or the drug is removed, the bone marrow starts making more megakaryocytes and makes more platelets, so the platelet level goes back to normal. If the bone marrow is affected, there is no way we can compensate for the thrombocytopenia, and this becomes a chronic problem. Well, how these patients present? Remember, we have 2 types of bleeding, the platelet type and the blood clotting type. They are going to present with superficial bleeding from skin or mucous membranes, platelet type bleeding. Okay. Also, they can present with any symptoms of the viral illness, okay, weight loss, headache, fever. The disease ranges from minor bleeding, some petechiae, some purpura for several days, or in some cases can have major hemorrhage from mucosal sites, epistaxis, hematuria, menorrhagia, bleeding gums. So the bleeding varies. We are going to see that something that is important is that these patients don't have splenomegaly or hepatomegaly and don't have any lymphadenopathy. Remember, when we have these bleedings, immediately we have to rule out leukemia, we have to rule out hematologic malignancies and other processes. So in our physical exam, always we are going to look at the abdomen. So no splenomegaly, no lymphadenopathy, no hepatomegaly. Okay, there you have something interesting. Less than 3% of them have splenomegaly, like the general population that can have normally spleen that is larger than average. Normally they have bleedings, but they are not internal bleedings. They don't have a cerebral hemorrhage or nothing like an internal bleeding. There is a note for you to know something about this ITP, because we say, oh, this is a normal self-limiting disease, no problem, just little amount of people progress to chronic. During pregnancy, something can happen in women that have ITP or don't have ITP. Then we have 2 cases. A woman with ITP may have a newborn that is also thrombocytopenic, because the fetal platelets, if they express the same antigen as the mother, the maternal antibodies are going to cross the placenta and attack the platelets of the baby. Now, in some cases, the woman, the mother, doesn't have ITP, but makes antibodies against antigens that are expressed in the fetal platelets that come from the paternal side. So either if the mother or the father have ITP, and the fetal platelets have this antigen, there will be an attack against the platelets of the fetus, and the fetus or the baby is possible that they are born with thrombocytopenia. Well, let's stop for the minutes, okay, and continue later with TTP. Okay, please understand very well the difference between the names. Okay, names in medicine have a purpose. Unless they are the last name of someone, they have a purpose. And even that has a purpose. ITP is immune or idiopathic thrombocytopenic purpura, low platelets for different reasons, and people bleed from skin and mucous membranes. This has a name that is totally different, that is thrombotic thrombocytopenic purpura, TTP. Okay, this is a multi-system disorder, affects several systems, okay, that has thrombotic microangiopathy. What is the meaning of that? Thrombosis formation, thrombi in the microscopic blood vessels. Understand the names. Small, tiny, microscopic arterioles in all the organs of the body. Platelets aggregate, form thrombi, clog, okay, obstruct the circulation or the microcirculation of different organs. Notice the description. It's an idiopathic disease of acutely falling platelets. You're going to see this in your patient. Patient starts at 100,000, 90,000, 80,000, 70,000 acutely falling platelets. Understand the description so you see later the patient in your vignettes. Okay, any patient that has anemia and thrombocytopenia has to be in your differential. Is one of the don't miss diagnoses in medicine, and because it's 95% fatal if we don't recognize and treat the condition. The pathology, or what you find if you make a biopsy, are hyaline thrombi in the capillaries. Hyaline, remember what is hyaline? Remember your cartilages that are hyaline, soft. Okay, a hyaline thing is something that contains proteins and is soft. Hyaline thrombi are made of something that is called von Willebrand factor, that we are going to study later, and platelets. Only that. These thrombi don't contain fibrin or red blood cells. Okay, no activation of the coagulation cascade around this. That will make a difference with the thrombi that we find in disseminated intravascular coagulation. If you want to know what the patient has, you might have to do a biopsy or an autopsy after they die, analyze these little thrombi. Do they contain red blood cells or fibrin? This was DIC. They contain only von Willebrand factor, okay, and platelets. So this is TTP. That's the way pathologists have to know what people died from. What are the risk factors? Well, this is more commonly seen in blacks, 9 times more at risk in females and in obese people. So when you put the three things together, imagine a vignette, black, obese, female. That is the classic patient. And not only in your vignettes, when you are sitting in an ER and you have a patient with anemia and thrombocytopenia and it's a black, obese female, oh my goodness, this is the type of patient of TTP. I have to be very careful and follow up her platelets because this woman can start forming thrombi everywhere and die immediately if I don't treat her. Okay, that's what has to come into your mind. Pregnancy is a risk factor near the term or the postpartum period. So imagine if we add black obese female 2 weeks after, or 1 week or 3 days after delivery, we are adding another risk factor, and people receiving chemotherapy or cancer therapies. Now, what happens in these people? We are going to study later, or now, right now, a molecule that is called von Willebrand factor. Okay, this protein has two roles in our body. Okay, one of them is this protein is a carrier protein for factor 8. Factor 8 is one of the coagulation factors. It is a very lazy factor that needs to go in a taxi everywhere he goes. So it needs von Willebrand factor to be transported from one side to another. This is very important because some people have von Willebrand factor deficiency. And if they have von Willebrand factor deficiency, they also will have factor 8, not deficiency, but simply the factor 8 doesn't move because it doesn't have the transporter. Okay, so we are going to associate von Willebrand factor deficiency with factor 8 deficiency. Okay, so it will give certain disorders as a result of this. Now, the other role of von Willebrand factor is forming a connection between the platelets and the damaged endothelium. Remember, the first step in this blood formation is the binding of the platelets, okay, to the endothelium, to the damaged endothelium. So this is the endothelium here that has been damaged. There will be expression of von Willebrand factor, and the platelets will bind to this von Willebrand factor. So if someone doesn't have this factor, platelets will not bind there. Okay? That's the link between the platelets and the endothelium. Now, some drugs, quinine, cyclosporine, tacrolimus, are definitely implicated in some cases of these TTP, but most cases are because of a genetic mutation, a dysfunction in a protein that is called plasma metalloprotease ADAMTS13. This is a test that we can do to the patients to determine if they have TTP or they are at risk. Mutation of this protein or simply immune destruction. Now what happens when we make the von Willebrand factor, as in many cases of many proteins, we make a huge protein. This protein, the ADAMTS13, breaks down the huge protein into smaller fragments that are the normal one that binds to platelets. If this protein is not working, we are going to make extremely huge von Willebrand factor. Okay, and this is the one that will form the microthrombi. Remember what these hyaline thrombi were made of, von Willebrand factor and platelets in the process of these TTP. So, extremely large von Willebrand factor and platelets will form microthrombi throughout the entire vascular system, damaging whatever organ you want to put here. The kidney, the brain, the lungs, the pancreas, adrenal glands, whatever organ you imagine. Thrombosis in many different places of the microcirculation. So this is the typical patient, 30 to 40-year-olds, obese black woman. They will have 1 to 2 week prodrome. They are going to feel bad for a while. Fatigue, weakness, malaise, sometimes diarrhea and vomiting. They get to the ER and they say you have a virus. Take loperamide, take this, take that. Go home. If you feel better, stay home. If you feel bad, come back. And they present, when they really develop this TTP, with a pentad, classic pentad. Remember, patients are not going to present with all the 5 things. But these are the 5 things that classically are found in these TTP. Intravascular hemolytic anemia. Remember what you see in the blood smears, histocytes, and you see low haptoglobin because the haptoglobin is binding to the free hemoglobin. Okay, renal failure, remember these thrombi are forming in the kidneys. Acute renal failure, you see proteinuria, hematuria, and elevated creatinine, 1.1 or sometimes more. Extreme, please, when I write these things, read well. Extreme thrombocytopenia, from 10 to 20,000 platelets per microliter of blood. Okay, acute falling platelets. If you test the platelets every, let's say, 2 hours, 3 hours, you are going to see the rapid decrease in the number because they are being consumed, making thrombi in all of the micro blood vessels of the body. Ischemia in the brain, neurologic signs that can appear in 65% of the people. Memory disturbance, behavioral irregularities, headaches, coma. Sometimes we can't even think, oh, this person maybe is under a drug, maybe this person is doing this, she's crazy, or he's this, and we don't realize what is really going on. And some of them will have fever, only 33%, anemia, bleeding of the platelet type, and something that we can do to determine, it's not specific for TTP, elevated lactate dehydrogenase, which simply means these persons have tissue injury. LDH is an enzyme that tells us that there is tissue injury somewhere. Hemolytic uremic syndrome looks similar to TTP, but appears in children, can appear at any age, but usually appears in children as a result of a toxin that is produced by a strain of E. coli 015787. If we see this in adults, looks exactly as TTP. Sometimes it's very difficult to distinguish. Okay, imagine a person, an adult that took a raw meat or a hamburger in some place and developed this TTP. We don't know if this is HUS or this is TTP. And can result in thrombosis formation everywhere, including the kidneys. The most common complication is renal failure, sometimes needing dialysis. Or transplants. Transplants are cheaper than having a person in dialysis all their life. One of the marks of this hemolytic uremic syndrome as a result of the damage in the renal failure, in the renal function, is bloody hematuria, elevated creatinine, but also they will present with bloody diarrhea and abdominal pain, seizures if the brain is involved, and they can develop fulminant thrombocytopenia with hemolytic anemia. Okay, remember you are going to see the classic presentation, and we're going to talk later. The treatment is going to be dialysis. That works very well in children, but very bad for adults because of the similarities with TTP. There can be two types. One that is epidemic as a result of the Shiga toxin produced by these bacteria. This toxin will bind to the glomerulus, to the endothelium in the glomerulus, causing damage, detachment of the endothelium, exposing the basement membrane, forming thrombosis because of activation of the coagulation cascade, okay, hemolytic anemia, fragmentation of the erythrocyte, forming, remember, schistocytes, platelet destruction, and renal failure. And there is one that is non-related to this toxin. It's called infectious. And this is produced mostly by Streptococcus and other bacteria that also damage the glomerulus, exposing antigens, triggering an immune reaction, and endothelial damage. The one that is more important for us is the first, the epidemic one, okay, that typically appears in children. There is a past history of undercooked meat. In the vignettes, normally children went to a camp or went to a family house for a barbecue and they ate burgers that were undercooked or something like that. Normally this is found in epidemics, in different, there are histories of fast food chains or different other foods that were contaminated with E. coli that led to different epidemics. They present with bloody watery diarrhea, no fever generally, anemia, thrombocytopenia, signs of renal failure, signs of intravascular hemolysis, schistocytes, the blood cells are broken in these thrombi, increased LDH, tissue damage, and decreased haptoglobin because of the binding of haptoglobin to free hemoglobin. And here we have what happens when someone has deficiency of this von Willebrand factor. Okay, this is the most common inherited bleeding disorder, bold and red letters. Okay, there are different types. In one of them, there is low secretion. Right? They produce low amounts of von Willebrand factor that otherwise works normally. And the other two types are in which they produce normal amounts, but is defective. Okay? Defective von Willebrand factor. The only difference between them is that one is autosomal dominant and the other is autosomal recessive. Okay. Von Willebrand factor normally is produced by endothelial cells, secreted by endothelial cells and produced by the liver, binds to platelet surface, and has receptors on the platelets. This receptor on the platelets is called glycoprotein 1b. Later we are going to see a picture in which you see the endothelium, the basement membrane of the endothelium, you see the von Willebrand factor and the receptor for it, that is the glycoprotein 1b. Okay? Attachment of platelets to the endothelium. Any deficiency will produce episodic increase in the bleeding time and ecchymosis with normal PT and PTT. Why the PT and the PTT are normal? What is the problem? Is there any problem in the pathways of the coagulation? So when you measure PT and PTT, they are going to be totally normal. The bleeding time, well, this is a test that we normally don't do nowadays. It's like a torture. Yeah, you apply a blood cuff, then you cut the patient and you wait. They are bleeding and bleeding and you wait and count the time until they stop bleeding. No, nowadays it's not necessary to do this thing. So they are going to present with episodic mucosal bleeding, okay, the platelet type bleeding. This is very important that you read well, okay? Episodic, something that happens once in a while. It's not every day these people are bleeding, okay? Sometimes it goes undiagnosed. Some people once in a while have nosebleeds or gum bleeds or ecchymosis. So I have blood vessels fragility, capillary fragility. How do you know that? Because they have easy bruising or easy bleeding. They haven't done any tests, so we don't know. So may go undiagnosed. Under stress, there can be exacerbation. Well, there I put something there about the diagnosis, but we are not going to enter in that because that is totally medicine. Okay. Of course, if you measure the amount of von Willebrand factor, it's going to be low. But there are other tests that you are going to learn in medicine that we really don't have time to enter in that. And then you have the treatment just for medicine. We treat it with ADH, desmopressin, that induces von Willebrand factor secretion. I put this for you to understand something. Remember, people with the type 1 von Willebrand factor deficiency produce a little of the good type. So if you give desmopressin, they are going to produce more of the good type, and you can fix this. But if someone has the type 2 or the type 3, they produce normal amounts of the wrong type, and you give ADH, they are going to produce more of the wrong type. So you are not going to fix anything. But this ADH, this desmopressin, only works in people with von Willebrand factor deficiency type 1. Affects 125 persons per million people. Okay, the severe type affects only from 0.5 to 5 persons per million. The severe type is not as frequent. Okay. There are reports that are done that say that the prevalence of this condition is close to 1% of the population. Remember, this goes undiagnosed in many people, so the exact prevalence of the condition is very hard to know. These are the functions that we already mentioned: adhesion of platelets and protect the factor VIII from degradation. There you have the diagram. We are going to see this diagram several times today because we are going to study 3 diseases One of them is von Willebrand factor deficiency, which we don't have this, or this is abnormal, so the platelets don't bind here. But there are other receptors. You have here the GP, the glycoprotein 2B3A. That is this little thing here. It's the one that binds one platelet to another by using collagen. There's a receptor for collagen. Okay, any deficiency in this receptor will give something that is called Glanzmann thrombasthenia. It's a problem in another receptor. Okay, and then we have another receptor. That is the GP1B. That is exactly this. If we have deficiency or mutation in this receptor, people are going to have Bernard-Soulier syndrome. Okay, so if this is missing, von Willebrand. If the green one, the platelet receptor is missing, then that is Bernard-Soulier syndrome. These other conditions are not as frequent as von Willebrand disease, but they tend to appear in boards very frequently. So we have to know what is what. And in medicine, you are going to know how or what tests you do to differentiate them. For example, what is this useful for? Imagine someone has bleeding, and they have von Willebrand factor deficiency, so they don't have this. Are you going to give it platelet transfusion to these people? No. These platelets are going to be very good in number, but they're not going to find any place to bind to. Now, if someone has Bernard-Soulier syndrome, they don't have the green protein, and they're bleeding, and you give platelets, good platelets, that's going to work. Because these are normal platelets that you're giving, that they are going to find a parking space, and they're going to be able to bind them. That is the objective of this. That is what you really have to try to understand, the applications of these things that you're studying for the clinical practice. Well, people with von Willebrand disease will have bleeding for minor wounds, postoperative bleeding, family history. Remember, autosomal dominant, the 1 and the 2, autosomal recessive, the type 3. So this appears in family depending on the pattern of inheritance. Will appear more or less. Easy bruising, excessive bruising, menorrhagia, epistaxis. Notice that I put there for more than 30 minutes. When someone has epistaxis because of dry nose, tends to last for some minutes, maybe 2 minutes, 3 minutes. If you compress, it's going to stop. If you start touching there, it's going to continue. But if they're taking aspirin, of course, it's going to last longer. But these people are going to have epistaxis for more than 30 minutes. Difficult to control epistaxis. Okay? They have history of family bleeding. They have requirement of transfusions. Remember the platelet type bleeding. In children, we are going to see, for example, bleeding from the umbilical stump after they are born. Okay, excessive bleeding, difficult to control. Cephalohematoma, hematomas in the brain. Cheek hematoma, conjunctival bleeding, post-circumcision bleeding, post-venipuncture bleeding. Sometimes parents or the people who are taking care of them can be accused of abuse because they have bruisings everywhere. So this is very important to remember. Not every bruise is because of abuse. We have to, okay, sometimes imagine if they have the family history, it's very easy, but if they are adopted, for example, we don't know, because maybe sometimes we don't know the family history of people. Bernard-Soulier, okay, this, we go to the, later we're going to see the picture again. It's going to have more or less the same presentation. Okay. There are some tests that we can do to determine if they have this condition or not. But one thing that we are going to find is giant platelets. Okay. This doesn't appear in von Willebrand factor deficiency. So in boards, in tests, they can give you a blood smear and tell you there are giant platelets. Oh, this is Bernard-Soulier. Bernard starts with a big, with a B, so big platelets. Okay, B for big platelets. And use the mnemonic that works good for you. Autosomal recessive defect of the platelet GP or glycoprotein 1B receptor is the green one, the one that binds to von Willebrand factor. Okay, this is the one that we can treat by using platelet transfusion Okay? It doesn't work in von Willebrand disease. And in this case, there is a chronic, severe mucosal bleeding and giant platelets in the blood smear. Okay, so we treat Bernard-Soulier by giving platelet transfusion. We treat von Willebrand disease or factor deficiency type 1 by giving desmopressin. It's very rare, 1 case per million or less, and more common in boards. So we have to study this. So remember, this is the receptor for von Willebrand factor. If there is a decreased expression, any mutation in this factor, there will be a deficient binding of von Willebrand factor to the platelet, resulting in defective adhesion of the platelets. This is very important to differentiate this from the next condition that we are going to study. This is a deficiency in adhesion. Okay, the green receptor to von Willebrand factor. We are not going to enter into the Risto setting test. That is very complicated to explain. That is for medicine. Then you have a blood smear with the giant platelets. Okay, normally, platelets have to be tiny. Okay, extremely tiny, like this thing here. These are giant platelets. Okay, this green, remember, is the platelet receptor for von Willebrand factor. So there is a problem in this binding here. Okay, then we are going to study Glanzmann thrombasthenia, in which there is a problem with this GP2B3A. That is the one that helps one platelet to bind to another. Platelet aggregation. Glanzmann thrombasthenia, autosomal recessive. Okay, the problem with the GP2B3A, the one that binds to fibrinogen. Another name, you don't care about this. Also rare disease, produces mucosal bleeding and also giant platelets in the blood smear. Okay, we can treat this as well with platelet transfusion. Okay, so we have now two conditions with giant platelets. But in this case, the problem is going to be with the platelet aggregation. Okay? The problem is in the platelet aggregation. In medicine, you are going to study several tests to distinguish one from the other. One is the Risto setting test, and the other is the ADP test. Okay, we are not going to stop to explain this because that is for medicine. For pathophysiology, the most important thing you have to remember is that there is a problem in the platelet aggregation. Okay, here, while here we have a problem in the platelet adhesion to the endothelium. Okay, that is the most important thing to remember for patho in hematology. We're not going to be talking about these diagnostic tests, nothing like that. Then we have to cover some coagulation disorders. The first one is going to be disseminated intravascular coagulation. It's really it's very difficult to place this disorder in one or another classification because you have a lot of consumption of platelets. So you can put it in the platelet disorders because of the excessive consumption. Okay, there is it's very difficult. Important thing is to understand what is going on with these patients and the possible causes, the risks, and what type of patient is at risk of developing DIC. Acquired condition, there is nothing here that is inherited or congenital, in which there is a widespread activation of the coagulation cascade and formation of many clots, fibrin clots. Very different, the clots here. Okay, remember these are going to contain red blood cells and fibrin. It's not like the ones in TTP that contain von Willebrand factor and platelets only. This widespread widespread formation of clots will lead to ischemia, thrombosis everywhere, and multi-organ failure, and bleeding from every place you can imagine because of the consumption of platelets and clotting factors. These are the conditions associated with DIC. You have many, many, many conditions in which you can have DIC as a complication. Some tumors, some malignancies like leukemias, acute leukemia, metastasis of cancers like pancreas and prostate. Some infections, the most important infections, the ones that you always have to think is the gram-negative bacteria. Most gram-negative sepsis can lead to DIC because they produce some endotoxins. Some cases of gram-positive bacteria as well, viral infections, hepatitis, cytomegalovirus, dengue virus, HIV, and some other infections. Also, always think of DIC as a complication of pregnancy, okay? Eclampsia, preeclampsia, more commonly placental abruption, also amniotic fluid embolism. Amniotic fluid can go into the blood and produce or activate the coagulation everywhere. Dead fetus syndrome, all of the products, woman is pregnant, the fetus dies, all of these toxins, all of these things are going to start going into the circulation. Head trauma, common complication of head trauma. Okay, different extensive burns, crush injuries, tissue necrosis, okay, hypothermia, hyperthermia, liver diseases, intravascular hemolysis after a transfusion, some medical devices like prosthetic devices, etc. Secondary to shock, cardiopulmonary arrest, and some vascular disorders. There is a syndrome, Casa-Bush-Merritt syndrome. I put the link there for you to see what is that. It's the combination of a giant hemangioma, thrombocytopenia, and that thing. And it's coagulopathy, okay? Excessive consumption of the blood clotting factors and platelets will lead to DIC in cases of these cases. Well, there you have the pathogenesis. Okay? There you have the pathogenesis. You have the causes: trauma, sepsis, cancer, pregnancy, endothelial injury. Okay? All of these will lead to endothelial damage, inflammation, inflammatory cascade with cytokines and chemokines, release of tissue factor everywhere, all of the blood vessels of the body with endothelial damage, and all of them releasing tissue factor. What happens? You have an activation of the coagulation cascade, because once you activate one, this activates the other. So blood clotting everywhere, widespread microvascular thrombosis, occlusion of the microscopic blood vessels, hemolytic anemia in these thrombi, consumption of the platelets and clotting factors, ischemic damage everywhere. The consumption of the platelets and clotting factors will lead to widespread bleeding. So you're going to have lysis of these clots with the elevation of the D-dimer or fibrin degradation products. Okay, all of this is what you are going to have in the pathogenesis of this condition. So the clinical manifestations are thrombi and bleeding. Okay, thrombosis, occlusion, ischemia everywhere, and bleeding everywhere. Imagine how difficult this is to control. Widespread hemorrhage. More than 3 unrelated sites are necessary for the diagnosis. You can have nasal, urinary, and gastrointestinal bleeding, or all of the sites that you want to imagine. Okay? Oozing from puncture sites. You draw blood, you put a catheter, and they start bleeding and bleeding and bleeding and bleeding. From incisions, from mucous membranes. Acrocyanosis. Acrocyanosis is distal cyanosis because occlusion, thrombosis, and ischemia in the hands and feet. Okay? In the CNS, in the brain, you can have hemorrhage, subarachnoid hemorrhage. Okay? You can have alteration of the state of consciousness. It can be from confusion to coma. okay, or from confusion to convulsions to coma. GI bleeding that can be either occult bleeding or can be massive bleeding, abdominal distension, pulmonary infarctions, acute respiratory distress syndrome. Okay, all of these inflammatory processes in the blood also can alter the permeability of the capillaries in the lungs, producing a non-cardiogenic pulmonary edema, ARDS. Cyanosis, tachypnea, hypoxemia, also bleeding from the renal system, hematuria, oliguria because of the failure of the kidneys as a result of the thrombosis, okay, and cardiac problems, hypotension, tachycardia, okay, and also infarctions or whatever you can imagine as a result of the bleeding and as a result of thrombosis in the coronary arteries. So, you can make 100 more slides if you want, adding things and things and things as a result of bleeding, as a result of thrombosis in different organs. Well, the last things that we have to cover, or there is more. Oh. The last things that we have to cover are the hemophilias. Hemophilia, love blood. Okay. There are two types. Okay, these are as a result of deficiency of some clotting factors. They are X-linked, so they are going to be present males. X-linked deficiency in factor A, which is the most common type, will lead to hemophilia A. This will present with hemarthrosis. Okay, remember the blood clotting type bleeding is not going to present so frequently with the superficial bleeding from the mucous membranes, more with hemarthrosis, easy bruising. In the lab, there will be prolonged PTT, normal PT, okay, intrinsic pathway. Here is where we have the factor 8. So when you measure the PTT and the PT is going to be normal, the PTT is going to be prolonged. What that means, it takes longer to go from here to here. So the coagulation is delayed because it takes longer. Prolonged PT or PTT will be increased tendency to bleed because it takes a lot longer to these reactions to occur. Can be acquired because of an autoimmune condition or can be inherited in the X-linked fashion. And we simply, when we do a blood test, we measure the levels of factor 8. The time, if you do this thing, to detect the bleeding time is going to be normal because the platelets are okay. When you measure the bleeding time, you are measuring the function of the platelets. If they have normal number of platelets, normal platelets, or any of the platelet-related disorders. Von Willebrand factor, Glanzmann, Bernard-Soulier. In those cases, the bleeding time is going to be prolonged. But in cases of coagulation or clot factors problems, the bleeding time is going to be normal. The PT or PTT are going to be altered. Okay? How is it going to be the PT and the PTT in DIC? Both of them are going to be prolonged. Everything is going to be wrong in DIC because we are consuming platelets, we are consuming all of the clotting factors. And the treatment is simply giving factor 8 to these people. Okay, it's simply that. Hemophilia B is called Christmas disease. I really don't know why they call this Christmas disease. Some people use a mnemonic that is draw with Christmas tree and then write Christmas, and they have a 9 there.
So when it comes to factor 8,
Yeah.
how come with the von Willebrand factor deficiency, usually the levels of factor 8 also decrease, but how come then the PT and the PTT
Well,
are normal?
the PTT can be altered in von Willebrand deficiency, but it depends on the severity of the condition. Okay, in very severe cases, and remember, most cases produce an okay amount of von Willebrand factor. Okay, just a small percentage of the cases produce no von Willebrand factor. These cases are gonna behave like a hemophilia, and the PDT is gonna be elevated. Okay, very good observation. Okay, because even though they have, it doesn't work. Okay, so these pathway is gonna be. So here we have another X-linked condition, but instead of the factor 8, is the factor 9, the one that is gonna be deficient. Notice that the lab is okay, it's exactly the same. Elevator, prolonged PTT, normal PT, normal bleeding time. What is gonna be low is the factor 9, and the factor 8 is gonna be normal. Has identical presentation. We simply have to distinguish the diseases by what factor is missing, and simply treat by giving concentrate of factor 9 instead of factor 8. It's very important to make a differential, because if we give 8 to one that has a hemophilia B, we are doing nothing. Okay? This is the incidence in hemophilia A, 1 in 5,000 males. Hemophilia B, 1 in 30,000 males. Okay, this is the amount of babies born every year, 400 babies every year in the USA. Okay, this is the prevalence, estimated to be as 18,000. Okay. Congenital hemophilia affects all ethnic groups and has a worldwide distribution. Most of them, remember, are classified as severe. Okay, so they have to be treated. Okay, it's not like von Willebrand disease. Remember, von Willebrand disease, most cases are never diagnosed. So we don't know the exact incidence and prevalence, because they have minor bleedings that can be fixed at home, and they, I have this, I have that, and never seek for medical attention. But this case is hemophilia is really a severe condition that has to be treated in most cases. Well, the presentation depends on the level or the activity of these factors. Okay, may present with easy bruising, inadequate clotting of traumatic injury, or in severe hemophilia, spontaneous hemorrhage. Remember, deep bleeding. Well, finish hematology.